Okay, can you all see my screen?
Yes.
Yeah.
Yes.
Okay. Okay, so today we're talking about shock. This is where you can see a huge difference in the content based on the previous semesters that we've done and now, because shock involves multiple systems. Your heart is doing a specific thing, your lungs start doing a specific thing, the blood pressure starts doing a specific thing. So in the past, we've covered just respiratory problems, just cardiac problems, just kidney problems. But now we're covering the integration of where all these different systems work together. And they're trying to be helpful and save the person. But what happens is, have your kids ever tried to help you and they ended up making a bigger mess than it would have happened if they hadn't helped you? I know this has happened to everybody. Shock is an example of that. The body thinks that it's doing the right thing by trying to help, but what ends up happening is the cascade of events where the body is trying to help and fix the problem ends up becoming the problem. And so the end point of shock is their DRT. They're dead right there. You have to work, you have to do something to be able to fix this where the body can still function and still do the work that needs to be done. And that's what shock is. Shock is a life-threatening condition. So we said it can kill you, okay? This is where the tissues are not getting the oxygen that they need, and they're not getting the glucose that the body needs. And so as a result of not getting oxygen and not getting glucose, then cells start to die. And this is where the perfusion is the problem, okay? So shock happens once it starts for whatever reason. There's about 5 main different reasons it starts that we'll be covering a little bit later on. It's going to affect all the body systems. So shock can be something that the body's fighting and the body's holding its own. It can progress very slowly. So you have time to see that that patient is no longer getting better and they're starting to point downhill. Or they can be fine and talking to you, then bam, they are not fine and they are having problems. So it can happen quickly or it can happen slowly. Now, shock protocols is something that's happened over the past 3 or 4 years because shock is very much preventable. We know the predictability of the course of shock, but we will literally hospitalize patients just because they have the potential risk of shock. Frankly, I'd rather be in the hospital having the potential risk of shock. And through this, we do specific care pathways to be able to focus on the prevention of shock. So we'll get 2 gray tubes. We'll be doing lactates. We'll be doing blood cultures, 2 different sets of blood cultures. You always want to do your blood cultures before you give medicine for decreasing fever and before you use any antibiotics to help get rid of the bacterial infection. We want to get them good while they're rocking and rolling and burning up hot with fever, and while those bacteria are just having a great party within the bloodstream. That's when we want to draw our blood cultures because that way we can find out specifically what microorganism is causing it and figure out which antibiotic is most likely to kill it. So we always want to draw 2 sets, 15 minutes apart from 2 different locations. And that way it helps us to ensure that we're not just getting a contaminant. For instance, if I just pull the blood from the IV line, is it possible that my IV is a site of infection? Absolutely. If I pull both sets of blood cultures from that one line, then it will make sense that both sets are showing bacteria within the blood. However, that does not mean that it's a systemic infection. The other thing is we will draw a lactic acid or a lactate, and we have to send this down to the lab on ice. If we don't put it on ice, then what will happen is it's not an accurate representation of the level it is within the body. It continues to deteriorate at room temperature over time. And so once we are able to get the patient over the risk for developing full on shock, then we can discharge them home. Now, the way we're going to know that is several different things. One will be lactate, one will be white blood cell levels. If it's a form of septicemia, which is bacteria that's actually in the bloodstream. And as we talked about, the end products, the cascade of events that happens when that first domino is touched, that first domino that causes the cascade of shock could be from bacteria in the blood. And that would be septic shock. It could be cardiogenic shock. It could be the person's had an MI and the pump's not working well. And then that was the first domino that caused problems and inadequate tissue, inadequate perfusion, inadequate nutrition to all the other cells. It could be a problem with a spinal injury, neurogenic shock. Neurogenic shock is most common with any kind of injury above T6. It could be hypovolemic shock. If my patient has a bleeder somewhere, then it could be hypovolemic. They're losing blood and the system doesn't have enough blood flow to be able to continue. So regardless of what the initial domino is, the initial cause, the end point is the same. So different classifications of shock. Hypovolemic shock, this is resulting, something's happening to our fluid. It's a problem with the fluid. So since it's a problem with the fluid, how do we fix it? We put more fluid in, okay? Whether that first we will be giving in situations of shock, hypovolemic shock, if it's a trauma of some sort, then we will be using lactated ringers. The reason for that is I can give less fluid and create more plasma expansion. Okay. So what this means is I can fix the problem in less fluid. So I don't have to worry so much about fixing the hypovolemic shock and throwing them into fluid overload. Okay. So with lactated ringers, instead of normal saline, I don't have to worry about that as much. So we replace the fluid. Cardiogenic shock. This is impairment. Something's wrong with the heart. It's not able to pump for whatever reason. Okay, that can be an MI. It could be cardiomyopathy. It could be cardiac tamponade. There's several different mechanisms that can throw you into shock. Or it could be a problem of the fluid distribution within the body. Okay. And what this means is we've got the fluid, but part of our blood vessels are being wonky and they're dilating when they should be constricting to push the blood flow back around, right? If it's dilating, this is going to pull in certain areas. And this is how neurogenic shock happens. So once my body realizes that it's in trouble, it will do everything that it can to try to fix it. And it does a really good job at that for a long time. But what the problem is that we can't always predict how long somebody can compensate. So what this means is their respiratory rate is going to increase because they are trying to get more oxygenation in because the tissues are not being perfused enough. Okay, so the initial insult is whichever domino cascaded to create the pattern of shock. The body tries to fix it and create homeostasis. And so, as a result of that, we have several things happen. Our sympathetic tone, our whole body gets in fight or flight. So, what's that going to be? Increased respirations, increased blood pressure, increased heart rate, okay? Increased cardiac contractility, how strong the heart is pumping. It's going to be activation of the renin-angiotensin-aldosterone system. Now, remember, that helps the body decide how much fluid it's getting rid of and how much it's keeping. If I've activated this system, then I'm going to dump aldosterone, which is going to make me hold all my salt, right? After I hold my salt, fluid follows. So the renin system's trying to fix the problem tomorrow, but it can't fix the problem today. Okay. So that is going to decrease my urine output after activation of this because I'm holding on to all my fluid. Increased catecholamines, epinephrine, is going to cause cortisol to dump. Anytime we have cortisol dump, you give a patient a steroid, what happens to their blood sugar? It goes through the roof. Okay, so this increases glucose for metabolism. And the goal of all these systems is to restore the glucose to where it should be, restore the oxygenation to where it should be, and restore cellular function to where it should be. So we can compensate for a good period of time when we're in shock. The problem is once we hit the crest of that mountain, we're compensating, oops, we're starting to plateau off. And then now we're going to become more unstable. What we don't know is how fast that is going to happen. So we, in adults, we have many predictive factors, okay? And the adult body will compensate, will try to fix things until all of a sudden it says, I can't do anymore, okay? And so at that point, then you start to decompensate. Your patient gets super sick, and now you're fighting the clock to try to save their life. So in kids, shock happens even faster. We literally, the kid will be looking at us, talking to us perfectly fine, and then 30 seconds later, will be unresponsive and in full on shock. So we don't have the compensatory mechanisms as strong in kids as we do in adults. So our stages of shock, we have that initial domino that happens. The body tries to fix it, tries to compensate for it, and then it progresses and it gets worse. And then eventually the patient's going to die. It's a matter of when it becomes irreversible. So during the compensatory stage of shock, the sympathetic nervous system dumps epinephrine. It's going to cause vasoconstriction, increased heart rate, and this increased contractility gets the heart to pump stronger. The goal of this is to maintain the blood pressure and to maintain the cardiac output. So at the time that something has happened that's life-threatening, are your kidneys that important? Not so much. What about your skin? What about that Big Mac you were eating? So, all of these areas in the body are considered not quite as important. So, the blood is shunted away from that. It makes perfect sense that the skin, it really isn't important for the skin to have good circulation at this point. We've got to keep the vital organs alive. So, we have cool, clammy skin. We don't want to be looking for a place to poop right now. So we have hypoactive bowel sounds. Everything's slowing down GI wise. This also is why people will feel nauseated right after a serious event has happened and they're going into shock, whether that be trauma, whether that be hypovolemic shock, whether that be cardiogenic or neurogenic. So ultimately, the tissues aren't getting enough oxygen, blood flow, and glucose. So if we're not getting enough oxygen to do aerobic metabolism, then we have to resort to anaerobic metabolism. Remember, that's not as efficient at churning out glucose, and it also leaves byproducts behind. Those byproducts are lactic acid. Okay, so remember we talked about gray tubes have to send down lactates or lactic acid on ice. And that is so we can see exactly how much anaerobic metabolism is going on in the body. Our respiratory rate increases, trying to blow off the carbon dioxide. We're trying to breathe faster to blow off that carbon dioxide. And so, as a result, as we're breathing faster, we may actually end up in compensated respiratory alkalosis. Now, as we have that carbon dioxide that's increasing, carbon dioxide that's increasing, our patients get confused because they're not getting oxygen to their brain. They're getting too much carbon dioxide building up, causing that confusion. And that is when we hit patients with BiPAP to help them blow out that carbon dioxide, that carbon dioxide. So after we've compensated, then all of a sudden we turn that crest on that mountain and we start to decompensate. So I can still fix it in the progressive stage of shock. Okay. What is happening is my body can no longer fix it and it's struggling. So, my blood pressure, the mechanisms that my body has to maintain my blood pressure can't keep the pressure up anymore. So, my blood pressure starts to drop and my mean arterial pressure drops. Now, my mean arterial pressure, the body likes to have a mean arterial pressure of over about 40 to 60. And when that decreases, the mean arterial pressure, what happens is there isn't enough, there's too much space for the amount of fluid. So my blood vessels, instead of tightening, they've now opened up. And so there's not enough fluid to fill those vessels. Okay. So the pressure is dropping, which means the blood that is getting to my brain isn't under enough pressure to be able to cause the oxygen to get off and the carbon dioxide to get on, which further causes more problems. So all the organs are suffering from not enough perfusion. And then this vasoconstriction. So what's happening at this point is the vasodilation has started, and then the body is sending out another help signal going, wait, now that my blood pressure has decreased, then this is going to create additional perfusion problems because at this point, the fluids have gone away from the parts of the body that need them the most. Okay. So, mental status changes happen due to that carbon diacid and decreased cardiac output and the low blood pressure. So, mean arterial pressure. If our patient is super struggling, then we're happy to have anything above 40 for kidney perfusion, okay? Now, with this, we prefer it to be over 60, over 65 for it to have sufficient perfusion. Okay, hey Sue Ellen, I'll change you once we finish. So we want to keep the mean arterial pressure high enough to create that pressure gradient. You remember those nightmares about the oxygen hemoglobin saturation curve and how the partial pressures change? All this goes back to that fancy stuff. Okay. All we need to know right now, though, is we want to keep the mean arterial pressure elevated. How are we going to do that? We're going to push fluids. First job, push fluids, push fluids, push fluids. Now, with that said, sometimes pushing fluids isn't enough. So we may need to give medications that are vasoconstrictors to help shrink the pipes to make the fluid that we have sufficient for the system. Arterial catheters. Now, in the past, you would see these all the time, okay? This used to be called, way back in the day, Swan-Ganz catheters. Now, you very rarely see it today because they're very finicky. The only time you will see them is sometimes in very risky surgeries or in cardiac ICUs, because if the patient is elevated in the bed away from the measurement where the measurement's actually occurring, then it will alter the pressure. So there's several ways that it can be false anyway, and it provides continuous moment to moment measurements. Okay? This is going to measure both systolic, diastolic pressure and the mean arterial pressure. Arterial catheters, these are put directly into the artery. So you're able to draw from them to be able to get frequent blood gases to be able to assess, are you in metabolic respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. So in the past, used to be in the neck. As technology has improved, radial access and FEM access are the most common locations now. So ideally, if vasoconstrictors have to be used, you aren't going to want a plain old venous hand IV, because what happens is these vasoconstrictors are often very bad about messing with the vasculature and making the vasculature very brittle. So you're likely to have extravasation of the IV. And in those situations, it will constrict the blood flow around any tissue that it has. If you cut off the blood flow, then you will often have necrotic tissue. So you can see patients' fingers. The fingertips turn black, and they literally may not be able to get blood flow back into them. And so over time, I actually saw a doc doing an assessment. He was a surgeon doing an assessment to see if we needed to do surgery on it. And he wiggled the tip of the finger, and the tip of the finger actually broke off. So it literally sets up dry gangrene. Now, an art line is not used for anything but for diagnostic capacity or for getting ABGs. Okay. This is for diagnostic treatment only. You are going to have separate venous lines that you can get blood out of, that you can put different things into. Okay. Um, and you need to assess frequently to make sure that it hasn't gone out into the tissues. And the patient has to be leveled. The machine that's measuring the pressure has to be leveled with the aortic root on the patient. So, decompensating shock, this is the progressive stage of shock. You'll hear it referred to both ways. Not only is the blood pressure starting to fail, it's starting to get to the point where we can't fix it. The lungs start to fail. The decreased blood flow causes further hypoxemia. Your carbon dioxide levels increase, causing more confusion, causing mental status changes, causing further problems with tissue oxygenation. The pressure gradient is no longer enough to keep the alveoli open. So once the alveoli collapse, it's hard to get them to pop back open. And we start to have pulmonary edema happen. When my patient has pulmonary edema, their lungs start to sound really wet. They start making gurgling noises, and they may be coughing up pink, frothy sputum. Pink, frothy sputum is always bad, never a good sign, and it's always a sign of flash pulmonary edema. So if you do not get your patient fixed and get this fluid off their lungs in minutes, then literally they will die on you. It is a very, very dangerous situation. Once my heart starts getting ischemic, then it's not going to be able to pump correctly. It's not going to be able to feed itself with blood and get enough oxygen because the lungs aren't working right. And so you're going to start to have cardiac ischemia, which is going to contribute to dysrhythmias happening. As your mean arterial pressure falls, the GFR of the kidneys can't be maintained, and you'll start to see creatinine levels go up because acute kidney injury starts to occur. Your liver function starts to deteriorate, your kidney function's deteriorating, your heart, your GI functioning has already started to slow down, and then you don't have enough oxygen or enough accessible glucose or enough pressure to maintain your blood functioning. So what happens is at this point, your liver's jacked up, your um, the different cells made by your liver, different clotting factors are now messed up. So what will happen is we can develop DIC. DIC is disseminated intravascular coagulation. First, what happens is the blood gets all sticky. It wants to put clots everywhere, everywhere within the circulation. Now, eventually, we're going to run out of platelets. And when we run out of platelets, then we have no way to stop the bleeding. And so from that point on, it's free bleeding. So early within DIC, we may be giving our patient heparin to help the thrombocytes not be so clotty. In late stage, when we have minimal platelets, do we want to continue to give heparin? No, because it's going to make them bleed worse. Okay, so first you're clotty, then you're free bleeding. So at this point, we have shifted into death is going to happen. It's just a matter of when. Okay. So at this point, the patient's not responding. Blood pressure remains low. The kidneys are starting to fail. We're having acute kidney failure. We're having acute liver failure as well. So all the organs are being damaged from the lack of oxygen. And often we don't know where that line is where we can get the patient fixed versus where it is all this is a futile effort. Okay. Often we can only look at cases in retrospect and say, oh, bam, right here, we should have known that for this patient, this is irreversible shock. So, what happens is we consider that the patient is in progressive shock continuously until death occurs, and then we know at some point they entered into irreversible shock. So, which stage of shock is characterized by a normal blood pressure? When's the body trying to maintain homeostasis? So that is a compensatory mechanism. Okay, so the body's trying to compensate, trying to keep the mean arterial pressure up until it can't compensate anymore. And then we're starting to have multiple organ damage that so severe that it can no longer can compensate. And that's when we get into progressive shock and then eventually irreversible shock. Okay, so that is what shock is the multiple types of organ failure that happens as a result of low oxygenation, inadequate blood flow, and the glucose is actually high, but it has a problem getting into cells. So what's happening is the cellular metabolism is shifting to anaerobic and dumping lactic acid as a byproduct. So now we're going to look at what is the first domino that falls. Okay. Is it a trauma happened and so you're bleeding somewhere, so you're losing blood in hypovolemic shock? Is it that you have spinal injury and that is going to create damage causing neurogenic shock? Or is it there's a problem with the pump, the heart, and it's damaged, so it cannot pump effectively to be able to push the blood around the body? So we're looking at what happens early on that causes the first dominoes to fall for shock. Regardless, when we're managing any type of shock, first thing is going to always be blood pressure is too low. We nail them with fluids. We push the fluids as fast as we can. After we've done a couple of liters of fluids, at that point, we assess to see, do we need to hit them with some blood? Um, and at that point, that's when we start looking at maybe we need some pressors. Maybe we need an ionotrope to actually improve cardiac contractility. So an ionotrope would be something like dobutamine to improve cardiac functioning, or dopamine at higher levels has cardiac functioning as well. So nutritional support. How do we need to manage nutrition? Should they even be eating anything? Um, and then ABCs. So you've got to make sure that they're breathing, their airway's good, their circulation's good. And if it's not, do whatever interventions need to happen. If my heart's not pumping, it doesn't matter how much IV fluid I put in them. It's not being pushed around the body. So I've actually seen patients, this has 3, 7, 11 pumps. I have seen patients with like double the number of individual lines. And this is really where you see the difference in ER nurses versus ICU nurses. The way these lines are would be enough to make a ICU nurse literally have a stroke because none of these lines are labeled appropriately. They're all knotted up in a big clotty mess. Whereas an ER nurse is going, I don't have time to figure this out. I'm working on saving the person's life. I don't care if they're in a knot. We'll figure it out. And so, with that, ICU versus ER, you'll see it in practice. So, fluid management, we want to give them crystalloid solutions. Okay. Crystalloid solutions are going to be like things that have crystals dissolved in it. Okay. So, sugar is a crystal, right? So D5 is a crystalloid solution. Salt is a crystal. Sodium chloride's a crystal. So that's a crystalloid solution as well. Okay. Now, a colloid means this has proteins in it. So albumin, that's a colloid solution. It pulls fluid back into the vascular system. What about blood products? Would those have protein in them? Absolutely. So plasma is considered a colloid. Whole blood is considered a colloid. And so first we want to hit them with crystalloid solutions. And again, LR, you can get more bang for the buck. You can give them less actual fluid, less risk of pulmonary edema, less risk of cardiovascular overload by giving them LR than multiple units of NS. If the fluids don't work, then we move on and we start giving things like Levophed or leave them dead. Okay, so we'll give them norepinephrine. We could give them dobutamine because it's an increased ionotrope. Um, and as we've talked about earlier, then we may need to long term be thinking about potentially TPN or some kind of nutrition replacement. Pressors. So in the urgent part, before we go there, pressors, I'm sorry, going back to nutritional support, we can just give them D5W as well, and that will give them enough sugar to be able to run off of to help stop some of the anaerobic metabolism. So vasopressors, this is Levophed or leave them dead. Vasopressin, we talked about that way back in the endocrine stuff. Vasopressin is antidiuretic hormone. So we are turning the kidneys down to pull the fluid back into the body. We also can give epinephrine and we can give neosynephrine. That's another form of vasodilator. So vasopressors are going to shrink the size of the pipe. That raises the blood pressure. Levophed increases contractility and rate. We talked about Levophed will cause extravasation and it can cause the fingertips to start having necrosis and eventual gangrene. If you have to use Levophed, it never goes in a peripheral IV. It goes in a central line. Now, remember way back to when we talked about central lines. Is a midline a central line? No, it is a long peripheral IV. A PICC line or a port is a central line, or in an emergency situation, an XJ, external jugular line, will be a central line. So vasopressin will help tomorrow, but won't help today because, again, it's acting on the kidney to decrease the amount of fluid that the kidney's getting rid of. Okay, so you never want to use vasopressin for the only one. Neosynephrine is not recommended for septic shock. Well, let's kind of think about that. That's a nose spray, right? So it's not going to be strong enough to be able to help everywhere. Vasopressors are going to increase afterload. It's making the pipes smaller, so the heart has to pump stronger to be able to push against all that pressure. If your heart is severely weakened, that can be the straw that pushes it over to the decompensated and irreversible shock. Vasodilators. If for whatever reason our patient's blood pressure is too high, then we would give vasodilators, such as nitroglycerin or nitroprusside. So this reduces preload and afterload, and it reduces cardiac oxygen demand. But this can cause hypotension. So it's a fine line with making sure our patient's blood pressure is stable. Ionotropic agents, talked about dobutamine being one. It's going to increase cardiac contractility. Dopamine at higher levels has cardiac effects. And so with this, dopamine and dobutamine increases stroke volume and therefore increases the cardiac output. However, you're making the heart work harder. So if you're making the heart work harder, then the heart's going to need what with oxygen? More or less? It's going to need more oxygen to be able to sustain that workload. The longer the patient is not getting the blood flow that they need, the worse off the patient is. So we also have to consider how long this has been going on. Early intervention with shock is what saves lives. And figuring out the initial domino, correctly identifying the cause of the shock, is critical to being able to fix the problem and keep the person alive. So with hypovolemic shock, we have some event that happens that decreases the blood volume. I'm losing blood somewhere. It decreases the venous return. Okay, the amount of blood that's coming back through the inferior and superior vena cava back to the right atrium. There's not enough blood, so my stroke volume's decreased. Stroke volume times heart rate is cardiac output. So if my stroke volume's decreased, my cardiac output's decreased. My tissues are being perfused less, and it's this nasty, vicious circle. So hypovolemic shock, we want to treat immediately with fluid replacement, potential blood replacement. Look at the distribution of fluid. Do we need to have some vasoconstrictors? Do we need some ionotropes to increase the functioning of the heart? So as nurses, we will put the client supine or in low Fowlers. In the past, we would use Trendelenburg. Trendelenburg is where we are dropping the head of the bed below the heart to increase blood return. What they have actually found with additional research is that really doesn't help anything. So we want to keep the patient supine or low Fowlers. We don't want to drop it into Trendelenburg. With hypovolemic shock, my skin says, hey, I don't need that blood. So I start to get really pale, and the skin itself will be cool and clammy. So when you start to see cool and clammy skin, start seeing some mental changes, you need IV fluid dumped in immediately. You want to push it in. We actually put like blood pressure cuffs around it to push it in, or have a person sit there and squeeze that bag in so we can get the fluid in as fast as we can. So what's my patient going to look like with hypovolemic shock? Low blood pressure, because the fluid is getting gone. So there's not enough fluid to fill my pipes. So my heart, to maintain cardiac output, is going to increase its rate. And so with this, my CVPs, this is my central venous pressure, is low. Okay. If it's less than 2, your patient is through. They're going to be DRT, dead right there. Okay. So low central venous pressure, they will die. Low urine output, you have to have an output of 30 milliliters per hour or less. The body is in distress. You're in trouble. And you always want to give fluid before you give pressors. So doing blood administration, since it's a colloid and we have actual protein and cells in it, we want a large bore IV. So an 18 gauge or larger to administer blood. That way it stops from damaging the red blood cells. Until I can figure out what type of blood somebody has, then I use the universal donor. That's O negative until I've had a type and screen done. We literally can administer blood on the side of the interstate now. LifeStar comes out, and if they know it's a bad trauma, they will have blood on the bird, and you can administer multiple bags of blood, O-neg, while somebody's still stuck in a car. They can go ahead and help do some of this fluid replacement. But for blood, you have to have a dedicated line just for blood. No medications can be given through this line. So, what kind of blood are they giving? It could be whole blood. It could be packed red blood cells. Now, if we're using packed red blood cells and we're kind of piecemealing it, packed red blood cells, fresh frozen plasma, because that's going to have all my clotting factors in it, is the plasma, and then platelets. Then I would want to replace a 1 to 1. And the reason for that is that basically is whole blood right there. Until we have some blood tests back and we can see, oh, they don't have enough hemoglobin. Their red blood cells are non existent. Then we know, oh, we need 2 more units of packed red blood cells. Or we look at it and see, oh, the platelets are gone. It looks like they're going into DIC. Then we can replace the platelets. Okay. So with that, we literally are told what to do by our patient's condition and the patient's lab values. So this is just kind of some cool equipment. This isn't something that the NCLEX is going to test you on or that we're going to test you on. However, we have warmers within emergency rooms because if somebody is experiencing shock, they are cool and clammy. Putting room temperature fluids in them requires additional metabolism to happen to warm that fluid up. So with this, we actually are able to warm the fluid prior to it entering the patient. Okay, so now we're talking about if that first domino is a heart problem. Okay, so that's going to be cardiogenic shock. So something has happened to my heart that it's not pumping appropriately. Since it's not pumping appropriately, then what is happening is my cardiac contractility, for whatever reason, it's not pumping right. Could be cardiomyopathy, it could be cardiac tamponade, it could be um, an MI. And I'm going to have to plug up. So hold on just 1 minute. Okay, guys. So something happens to the heart that it's not able to pump effectively. When the heart can't pump effectively, then that's going to decrease your stroke volume, which decreases your cardiac output. And that's going to end up with us having wet lungs, having decreased tissue perfusion, and then the heart can't feed itself the appropriate amount of oxygen and the appropriate amount of glucose. So, this decreased coronary artery perfusion further damages the heart, making the contractility worse, dropping the stroke volume more, and so further exacerbating the pulmonary congestion, etc. So, what do we do about this? We have to figure out what the problem is. Is the problem due to an actual physiologic something wrong with the heart? Let's pull an EKG, slap some tele leads on them, see if they're having an MI, see if they're having signs of cardiac tamponade. You're going to do that by looking for JVD, and you're also going to be listening for muffled heart sounds because that heart is being squeezed too much. So we want to correct the causes. We want to, first line treatment, make it easier for the body to get the oxygen. Put oxygen on them. Pain control. Pain control is preferable with morphine because morphine actually has decreased oxygen, decreased air hunger associated with morphine. So we would look at doing hemodynamic monitoring, figure out, hey, do we need an art line? Look at giving fluid if that's part of the problem. Look at drawing some tissue markers for cardiac damage, going way on back to that cardiac section, troponins, CPK-MB for myocardium and brain. Do we need something to take over the role of the heart? Okay, that would be a mechanical assist device, like an LVAD, left ventricular assist device. So that can help improve cardiogenic shock as well. So pharmacologically, my blood pressure too high, my blood pressure too low. If it's too high, then we would do nitroglycerin, nitroprusside. If we're trying to increase our blood pressure or increase the stroke volume, then we would do dobutamine or dopamine. We may need to make sure we get a central line so we could do other vasoactive medicines. Are they going into VT? Do we need to give them some amiodarone or some lidocaine to actually decrease the amount of arrhythmias that my patient's having? So the goal of nursing management is to figure out what can I do to help this person stabilize their body, okay? Do I need to give medicines to control arrhythmias? Do I need to give medicines or fluid to improve the hemodynamic status? Now, in cardiogenic shock, depending on where the cardiac damage is, if it's an anterior MI, I don't want to dump too much fluid because the heart won't be able to handle it. Okay. All the fluid is going to do is it's going to end up backing up and creating congestion within the lungs. Okay. So I need to do an assessment and figure this out. I may use an aortic balloon pump. Okay. Swan-Ganz, the art line that we talked about. And you're going to want multiple IV lines in this patient. So, cardiac shock can be obstructive, as we talked about with cardiac tamponade, where fluid is filling up in the pericardial sac, squeezing on the heart, making it not pump as well. So, this creates something, this basically is a form of cardiogenic shock. And how do we fix this? We go tap into that bag, the pericardial sac, and we suck out some of the fluid to make it easier for the heart to beat. That's called a pericardiocentesis. So, pulmonary emboli can create symptomatologies very similar to cardiac tamponade and obstructive shock. So, with this, if we suspect that it's a PE, we will either go in and pull out the embolus or we'll start the patient on heparin. So, tests that we would order a D dimer to see if blood's clotting anywhere within the body. The D dimer isn't going to say, oh, it's a pulmonary embolus. But if the D dimer is positive, it's going to say, oh, we need to start looking in the usual places. And so we'll look back behind the knees, the popliteal artery and venous system. We'll also be doing a CAT scan to see if there's an obstruction there as well. So other forms of distributive shock, okay? So circulatory shock, we're looking at the veins. We're looking at the vasculature. We're looking at how the fluid is distributed, okay? So if a patient has an infection in the blood, what's going to happen to their temperature?
It'll go up.
It's going to go up. So it's unlikely that they're going to be cool and clammy, right? They'll be on fire. So septic shock is a form of distributive shock. Neurogenic shock is a form of distributive shock as well. And then anaphylactic shock, we're going to cover it for completeness now, but we're going to be talking more about immunity and anaphylaxis later. Is there any questions about what we've done so far? Okay. So what is happening in circulatory shock? We have some kind of precipitating event, okay, whether that be neurogenic shock from a spinal injury, whether that be from bacteria in the blood, septicemia. So septicemia literally just means there's bacteria that's living in the bloodstream. It does not mean that you're going to go into septic shock. Sometimes these bacteria will cause vasodilation to happen. They'll release cytokines, or they'll cause the activation of cytokines in the body that causes vasodilation. This triggers the immune system response, and the body is trying to quarantine these bacteria. And as a result of it trying to quarantine them, it ends up messing up the circulation of the blood volume. So you have decreased venous return. If you don't have enough fluid going through your heart can't pump effectively. So it decreases your cardiac output, which further decreases your tissue perfusion, which causes more vasodilation, more activation of the immune system, and so on and so forth until death happens. So fluid replacement, we're going to want to replace with colloids. That would be normal saline, or I'm sorry, replace with crystalloids. Erase that. Crystalloids. So remember, sodium chloride is a crystal, okay? So that is a crystalloid. Lactated ringers is also a crystalloid, but it pulls fluid, kind of like albumin does, back into the bloodstream. But it is the only crystalloid that does that. A colloid has protein in it, okay? A colloid is going to be blood administration. It's going to be albumin, something with proteins in it. So we may need to, if we have components of hypovolemic shock, we're losing blood, then we may need blood components replaced, okay? So complications of fluid replacement, we give them too much fluid overload, pulmonary edema. So if we start to hear that their lungs have crackles, they're sounding wet, they're coughing, they're having difficulty breathing, they're having difficulty maintaining their oxygen saturation, then we need to look at the way we're ventilating them. We also need to look at potentially giving them some Lasix to get rid of that fluid. Okay, so you're caring for a patient in hypovolemic shock who's getting tons of IV isotonic fluids, normal saline. Nurse should monitor for, which one is it?
C, pulmonary edema.
Pulmonary edema. If you have signs of pulmonary edema, what do you do?
Give them Lasix.
Excellent. So vasoactive medications. When fluid isn't enough to fix the problem, then we may need to give some vasoactive medications to shrink my pipes and make them smaller. So this is going to mimic activation of the sympathetic nervous system. So when I give vasoactive medications, these are only going to be given in an IV, through an IV, and it will only be given in an emergency situation or ICU type setting. So we have to monitor the vital signs frequently because I can push it too far the other direction. Whether that be vasoconstricting, making my pipes smaller, or vasodilation, making my pipes bigger. So I want to move slowly on titrating the medicine, and this is often titrated to the patient's response. You want to give these through a central line, as we've talked about, due to they're very, very dangerous once they touch the skin. So with distributive shock, okay, septic shock, the reason it's a form of distributive shock, we're not actually losing blood volume. What's happening is this infection is causing the release of proteins that cause vasodilation. So when there's too much vasodilation, not enough fluid to fill it, we have relative hypovolemia versus true hypovolemia. Now, how are you going to tell the difference in true hypovolemia versus relative hypovolemia? In true hypovolemia, you're going to see blood somewhere, okay? Or you're going to see bruising and the potential mechanism, like potential internal bleeding, okay? Also, your skin is going to be cool and clammy. In septic shock, they're often running a fever. So are they cool and clammy? No. Okay. So it is a relative hypovolemia. Neurogenic shock results from loss of sympathetic tone. And the loss of sympathetic tone causes the pipes to open up, causing relative hypovolemia. So anaphylactic shock is due to an allergy, an allergen of some kind, whether that be peanuts, whether that be a bee, whether that be shellfish, that causes your pipes to open up, causing relative hypovolemia. Does it make sense the difference in relative versus true hypovolemic shock?
Yeah.
Okay.
What was you saying about one of the fluids in that you said in septic shock? It was the only fluid that.
The crystalloid that helps
Yeah.
to pull lactated ringers is a crystalloid. It is the only crystalloid that pulls fluid from other cells back into the bloodstream. Usually that's going to be a colloid because colloids have proteins like albumin that pull fluid back in. Make sense?
Yes.
Okay.
Thank
So, you're welcome. Can you have septic shock without septicemia? No. Now, can you have septicemia without septic shock? Absolutely. Okay. So septic shock, sepsis, always starts with septicemia. So this all septicemia is, there is bacteria within the bloodstream. Okay. And what this does, and we're not going to ask you to explain specifically how, all I want you to know is that the bacteria causes release of immune system functioning that causes vasodilation. And once we have too much pipe for blood, then the fluid is leaving the pipe somehow, okay? Because it's tight when it's constricted, okay? The cells are close together, it's tight. Once I open it up, then I have all these big gaping holes that the fluid can go through in the vessel to get out of the blood vessel, okay? So if you're interested in how that specifically happens, watch this video. Otherwise, just know the bacteria in the blood triggers an immune response that causes the vasculature to open up. Now, usually people that have an infection or have a fever, right? And we said that they're going to be super hot. Some bacteria actually alter the hypothalamus and alters the ability after that fever has happened. Because what's that fever doing? It's going to burn off the bacteria, right? It's a non-specific mechanism that burns off the bacteria. So early on, your temps are going to be high. Make sense? Later on, this bacteria can release a chemical that goes through the bloodstream up to the hypothalamus and turns off the hypothalamus's ability to control the body temperature. So later on in sepsis, you may see your patient's body temperature going down. And at first you're like, oh, we were at 103 and now we're at 101. We're doing good. Oh, look, now they're at 99. This is great. 98, we're normal, baby. But if we are still drawing lactics, which you should be, then you're going to see your lactate levels are still high. You're still going to see problems related to, yeah, our temperature is going down, but whoops, now we're at 95. Do we want our patient to be at 95? Not so much. Because what's happening is their hypothalamus has been wonky and now they can't control their body temperature. That's not a good thing. That means your patient's getting worse, not that your patient's getting better. So, screening for sepsis, whenever you enter your vitals, and there's certain combinations of this, your computers, your cows, are automatically going to trigger a sepsis protocol. And oh, you've got a temp that's too high or a temp that's too low, or your respiratory rate was 26 instead of 18, or your lactic acid is still too high, or your patient's having mental status changes. So any of these combinations of criteria are going to trigger a sepsis pathway. And so you need to know these different criteria that can trigger screening for septic shock. So our interventions for septic shock, we're very aggressive with fluid, okay? We push it till we get our blood pressure up, our heart rate down. We push it until we start to have wet lungs, and that's when we back it off, okay? So I'm going to want to do routine chest x-rays on this person, be able to see, listen frequently, like every hour, every 2 hours while they're receiving fluids to make sure we're not pushing them too far and making them get wet. We want blood cultures early from different sites before antibiotics, and we start broad spectrum antibiotics. So what this means is we're using a very, very, very large sledgehammer, okay? I can't do detail work with a sledgehammer, but I can make a dent in stuff with a sledgehammer. So broad spectrum antibiotics, I start off with a sledgehammer to kill the bacteria. Then once I get those blood cultures back and they have run a sensitivity as to which specific antibiotics is this bacteria sensitive to, what antibiotics will kill this bacteria, then I switch off Vanc and Rocephin or Zosyn or daptomycin, depending upon the severity of my patient's condition. I switch off them and onto the specific antibiotic that will kill the bacteria that the patient has. And that way, that's like instead of using a sledgehammer, that's like using a small finishing hammer. So I'm able to do more refined killing of bacteria. Neurogenic shock. So neurogenic shock often happens in some of these areas that are in red. You need to go ahead and add that into your notes. Neurogenic shock happens due to damage to the nervous system. This could be trauma to the spine. It could be neurogenic shock can be something that can happen frequently even after a person has had a spinal injury 5 years ago. Okay. So with this, we have injury to the spine at level T6 or higher. Okay. So above T6, T5, T4, C1 through 6. And what happens is we lose vascular tone. So when we lose vascular tone, that's a big fancy word that means we take our top pipe and we make it big, okay? Causing pooling of the blood in places where it shouldn't be. So with this, a hallmark sign of neurogenic shock is going to be bradycardia. So what happens is the sympathetic tone is being blocked from the spine. So we're going to have bradycardia and we're going to have warm skin. Okay. And that's because the sympathetic nervous system is being blocked. So the blood pressure immediately falls due to parasympathetic dominance, bradycardia, and lack of vascular tone. So what do? We treat with fluids, we treat with pressors, and we treat with atropine. Now, atropine blocks the sympathetic activation. Now, if my patient, going back to cardiac, if my patient has had a heart transplant, will atropine work on them? No. Now, this last bullet, you need to add this in as well, okay? The NCLEX loves questions on autonomic dysreflexia. Autonomic dysreflexia is a big 10-cent term that what it means is when an organ that's normally hollow is being compressed. Okay, so let's think about this. What are organs that are hollow? The bladder. The bladder is hollow and it holds pee, right? So as it gets compressed, as it gets too full, okay? So for instance, a patient has a neurogenic bladder and they can't activate the pee response themselves. If you haven't cast them and it's been 12 hours, that bladder's full, they may not actually perceive pain from it, but what will happen is their nervous system's going to go wonky as a result of the messages being sent from this organ and cause bradycardia and lack of vascular tone. Their blood pressure is going to drop. Okay. So at first, it will get very high, then it will immediately drop. So another organ that's normally hollow, the uterus. A pregnant woman who has a spinal injury. So as the uterus is expanding, you can have autonomic dysreflexia. That tends to be very, very messy because they have to plan on delivering early, for starters, or it's life-threatening to the mom. And they also will be stuck in the hospital with rapid cycling, checking their blood pressure, because you never know at what point that's going to be triggered again. And so, what if they haven't pooped for days? The large intestine is also an organ that is supposed to be hollow, right? So if it gets too full and starts sending those signals that, hey, I'm too full, it can be twisted within the spine due to the injury and cause autonomic dysreflexia. So during periods of sepsis, the body is using every resource that the cells have. And the cells are going to increase their metabolism, and they're going to try to make as much energy as they can. What is happening though, your backup stores are now depleted. Okay. So for instance, before snowpocalypse, you went and got bread and milk and eggs and toilet paper, right? Well, now that you've been home for a week and a half, ideally you've been home for a week and a half, then your stores, your backup supplies are now decreased because you've already used them all up, right? It's the same thing that happens to the body when it's experiencing shock. So I either can replace this with parenteral nutrition, and so this would be like TPN, or I can stick in a G tube, or I could stick in a nasogastric tube to put in tube feedings. So we need to make sure the GI system is able to work, okay? And with this, we also, if the stomach isn't being used, it's still making acid. So that acid can build up and cause problems. So we want to administer H2 pump blockers or proton pump inhibitors such as pantoprazole. The condition of shock is very difficult for all family members. And so you need to support the family members. It is a time period of high anxiety. You cannot say, oh, your grandfather's going to be okay. What you need to say is, we are giving him the best help we know how to provide right now. So you want to help educate the family about what's going on. By educating the family about the condition, that provides them with some level of control within this process. You will be confronting end of life issues, and people grieve differently. And so it's important that you recognize that and provide support for the family. Okay, okay. One more slide. Let's go ahead and knock this out, guys. MODS. MODS is where we have, basically, this is the fancy description of advanced shock. Okay. So we have multiple organs that aren't working right simultaneously. So this is MODS, multiple, M for multiple, O for organ, D for dysfunction, S for syndrome. Once I have multiple organ systems that are messed up and not working correctly, my rate of death has just gone through the roof. Okay. Because even if I can get one organ to jump back in and start working, then I still have another organ system that's messed up. And as you've figured out, especially through this lecture and through others this term, the body works together. And so we have a very high mortality rate once we have 2 or more organ systems that are starting to fail. So with this, it can be primary or secondary. So MODS could be secondary to septic shock. MODS could be secondary to anaphylaxis. It could be secondary to cardiomyopathy, to different causes. It could be secondary to a spinal injury, okay? But once we have more organ systems put together, and if we have 3 or 4 organ systems that are all going into failure, then that mortality rate is even higher, okay? So how do we stop it from progressing to this? We want to recognize the signs that the organs are struggling early. We want to do what we can to make sure they're perfusing well, whether that be providing oxygen, whether that be replacing blood products that need replacing, whether that be doing a nasogastric tube so you've got some kind of nutritional support. With MODS, you want to communicate with the family, let the family know what's going on. Start having some of those more difficult conversations because it's easier for the family to start anticipatory grieving. And the thing is, you don't want to say either way. You don't want to say grandpa's going to be okay. You don't want to say grandpa is going to die. You literally just say, we're doing all we can to be able to help this person. And they've got several different problems within their body. Then each of these problems can be very dangerous. So we're trying to do what we can to help, but that's the way that you will approach it. What kinds of questions do you have for me?
So I see where they've opened the school back up tomorrow. Are we still gonna do the Zoom thing and not meet at class?
Correct. We still have cars littered outside on my road, and it's still, we have like 3 miles of hills and curves to be able to get in and out of, and there's just not going to be any navigating it tomorrow.
Okay, that's good to know.